Good morning, and thank you for coming. Welcome to Leap into the Best Abstracts in Nursing. I do want to point out today is Friday, but it's really the 24th. That was a mistake on my part. This is the disclaimer slide from the NACFC. So I am Jacqueline Spano. I'm a nurse practitioner that is a researcher, I'm a care provider, and a newborn screening coordinator. I work here at Stanford University in the San Francisco Bay Area. I have no relationships to disclose. The session objectives today are to identify strategies used to implement evidence-based standards of care for persons with CF, foster a culture of continuous improvement within interdisciplinary CF care, and equip you, the session participants, with tools and methodologies for further analyzing clinical and outcome data to improve the quality of care in CF. The session overview of today, I'm providing a brief introduction, followed by Cindy, who will provide details about the LEAPP program. We will then have presentations from the LEAPP program graduates, as well as selected submitted abstracts to NACFC from APPs. We will conclude this morning with a poster viewing session outside there in the hallway. Up next is Cindy, who is going to provide more details about LEAPP.
Thank you, Jackie. And I also want to extend my gratitude to all of the LEAPP fellows who are presenting today and all of our invited abstracts. They come from as far away as Australia, so we're thrilled to have you here. I'm just going to start. So I'm a nurse practitioner. I have a doctorate in nursing from the University of Minnesota, and I've spent decades as a pediatric pulmonary nurse practitioner at Children's of Minnesota, and I retired from my clinical job a year ago. I am leading and co-directing, along with Jordan Dunitz, the LEAPP program, and these are our graduates who will be presenting today, along with our invited poster presenters. So if you've, please, these talks are meant to be like a quick little advertisement for the posters in the hallway. So we really encourage the conversations to continue. So why LEAPP? Well, LEAPP means Leadership in Education for Advanced Practice Providers. It came to fill gaps in the provider realm in healthcare, and this is happening not only in CF, but nationwide. The pipeline of physicians has been inadequate to meet the growing needs of a growing aging CF population. More are living better and longer, but with complex chronic conditions. And this has created gaps, and we are here to fill these gaps and fill them well. At a glance, the LEAPP program has three main components. First, I think the secret sauce of our program has been the partnerships with all of the resources from the greater CF community and our own communities. That includes CFF that provided funding, the CF Care Center Network. We partnered with the University of Minnesota for academic expertise to make this doable for adult learners and make it a very high quality program. Indiana University has online courses that we took advantage of. We used a quality improvement curriculum and PEP partnership. It was a partnership enhancement program curriculum that they also went through. So really the secret sauce is not about Jordan and I pulling together a curriculum, but it's about all of you out there who have contributed. The structure was a 2-year fellowship. They are finishing today. It was a 30% FTE funded by the CFF. This is in transition. It's going to look a little different in the future, but it was targeting those that were new to the APP role and or new to CF. They were all employed at their home center and credentialed there. So we have fellows from every U.S. time zone all across the country. We have 13 here today, so we're so thrilled to see them reach this milestone. The leadership was provided by Cindy George and the CF Foundation, and Jordan and I were program directors. It's been a great honor and privilege to work with Jordan through these years. And of course, as I mentioned, the academic support from the University of Minnesota. Wendy Lohman, who is a professor at the University of Minnesota School of Nursing, is here in the audience today. So thank you, Wendy, for being here. And then we had clinical mentors at their home center to provide that professional growth from novice to competent. And then professional mentors in the greater CF network, and all of them are here today as well. So thank you. And we also had Sarah, our LEAPP Cohort 1 grad, who you will hear from a lot this session, who led the QI course at the last 6 months of our program. And the results of this is what this session's about. So our LEAPP components, basically we had 3 major components. Was a curriculum that we built using a flipped classroom. The flipped classroom means fellows completed online didactic topic content. We did soup to nuts, genetics to lung transplant to palliative care and everything in between. We had a strong mentoring component, which I just talked about, at their home center and then in the greater advanced practice provider community. And then the last piece was a quality leadership and the quality, like I said, you'll hear about today. The future is going to look a little different, but the quality may be more suited to those with more advanced competency and offered to more mid-career APPs. So with that, I'm going to turn it over to our quality expert, Sarah, to introduce our speakers. Thank you.
Good morning, everyone. Just looking out, it's amazing to see you all here today. It really is a vision that was led by people that are passionate about the APP community, and to see a room full of people that are similarly passionate about the APP community brings so much joy to me. My name is Sarah Dykes. I'm a pediatric nurse practitioner at Dornbecker Children's Hospital in Portland, Oregon, so about 3 hours south of Seattle. I got to drive, which is very nice. So I'm pleased to all of you that took 3 flights to get here. Shout out to Jasmine. I do clinical work with CF, and then I've also had the privilege of getting to expand my acute quality improvement hat, or QI. As you heard, I was a fellow in the first cohort of LEAPP. And so it's also really special looking out in the audience and seeing my first year LEAPP cohort here. As Cindy referenced, I got to come back the second time around for the second cohort and get to teach the quality improvement section, which has, again, been a joy. And now to see you all here getting to share your amazing projects with the community is fantastic. LEAPP is supported by the CF Foundation, and here is a picture of my home hospital. An overview of the session today, we have our presentations grouped by topic. So the first is diagnostic testing, then we have lab testing. We have CF potpourri, your center and beyond, and then we'll wrap up with transition, which seems timely. We'll allow for a short question and discussion after each group. So please be friendly, interactive, come to the microphone or use the NACFC app. And then we'll have poster viewing out in the hallway for individual discussions, and where you can really get to see more of their projects and their quality improvement tools that they used to bring their projects to life. So with that, we'll welcome diagnostic testing to the stage. Beautiful. So this group includes Cynthia Johnson, who will be our very first presenter that you'll hear from today. Warm welcome to Cynthia. Oh, how do I go? I love that.
Great, okay. Hi, everybody. My name is Cynthia Johnson, and I am a pediatric nurse practitioner at the University of New Mexico's Pediatric Cystic Fibrosis Center. My project, Improving Bone Health Monitoring in Pediatric Cystic Fibrosis, focuses on increasing DEXA scan utilization to monitor bone health in children with cystic fibrosis. As we know, children with cystic fibrosis are at high risk for low bone mineral density due to CFTR dysfunction in bone cells, chronic inflammation, malnutrition, and steroid exposure, just to name a few. These factors can lead to poor bone health and increased fracture risk. Although the Cystic Fibrosis Foundation recommends DEXA scans starting at age 8 in patients who meet specific criteria, only 17% of our eligible patients had one completed. The gap prompted this quality improvement project. Our smart aim for this project was to increase the percentage of eligible cystic fibrosis patients ages 8 and older who completed a DEXA scan from 17% to 50% by July 31st, 2025. Using the Institute for Healthcare Improvement's model for improvement, our team tested several changes through plan, do, study, act cycles to identify what would work best for our clinic. Key interventions included creating a centralized Excel spreadsheet to reliably identify eligible patients, optimizing DEXA ordering during clinic visits by adding a reminder for these patients on our weekly pre-rounding clinic sheet, and utilizing Tiger Connect to message and remind providers before clinic visits about the need for a DEXA scan. These interventions led to a rapid increase in DEXA orders, reaching over 90% of eligible patients with an order placed. However, the numbers of completed scans remained low, only improving to about 33%. So while we successfully improved provider awareness and ordering habits, the completion gap revealed ongoing barriers in scheduling and family follow-through. This project highlights the value of clear eligibility criteria, simple tracking tools, and consistent team communication in driving change. The next phase will focus on closing the gap between orders and completion by improving scheduling coordination and follow-up. Our plan includes engaging our CF social worker to help with reminder calls and assisting families in getting scans scheduled and completed. Through this work, I learned how powerful small, structured changes can help in combination with a multidisciplinary team approach. I look forward to continuing my work to improve bone health management for my patients. Thank you.
Thank you. Thanks so much, Cynthia. Next up, we have Michaela Murphy.
Right. Hi, I'm Michaela Murphy, nurse practitioner in the Adult Center at Upstate Medical University in Syracuse, New York. The aim of my project was to increase expectorated sputum samples collected during in-clinic visits. Since the development of modulator therapies, for many patients, cough and sputum production has decreased. While this is wonderful, it means that over the last few years, we have been completing more throat swabs, and the collection of expectorated sputum samples has significantly decreased. We then have to consider, what is the clinical impact of this? Are throat swabs as accurate as expectorated sputum at identifying lower airway organisms? If not, then what are we missing? So the why here was really my why. Why did I pick this project? Why do we find it valuable as a team? The how, we couldn't figure out the how until we knew the patient's why. And these QI tools help to determine that. I appreciate that the Pareto chart helped us to engage with our patients and identify the factors that were most significant to them, which gave us direction. We then used the prioritization matrix to identify low-effort, high-impact interventions. Our center nurse helped keep me in check on this one. Really, we don't always know the consequence on other care members' workflow when we ask for something that may seem simple from our point of view. Run charts gave us real-time feedback on what was working or not working in our PDSA cycles, allowing us to adapt along the way. In the end, by giving patients time, privacy, information, and instructions, we were able to significantly increase our collection rates. We then evaluated the sputum cultures of patients who had provided only throat swabs for 18 or more months prior to the start of this project. There were significant findings in 39% of those. I know it says 29% up there, but at least my typo makes it look more impressive now. And if you want to know more about what we found in that 39%, you can come visit me at my poster, which there is theme music. The most important lesson through this project was that for successful and sustainable change, patients and staff must be engaged in the process. We were only able to make progress once we saw it from the patient's perspective. Interventions had to match challenges that prevented the patient from producing a sample. Changes also have to work for the team. As a group, we prioritized low-effort ideas. This steered us away from high-resource interventions, such as mailing out sputum cups for home collection or in-center sputum induction, which is often thought of as the next step. We instead learned that there were several other options that were feasible for both the patient and the care team. These proved to have a high impact. We were able to exceed our goal collection rate and improve the care for our patients.
Thank you so much, Michaela. Next, we'll be hearing from Barbara McDonald.
Hi, I'm Barb McDonald. I am a family nurse practitioner and I work at UAMS in Little Rock, Arkansas. So my aim or my study was improving DEXA scan screenings at an adult cystic fibrosis clinic. So CFF guidelines recommend routine bone density screenings, DEXA scans for all people with cystic fibrosis from age 18 and up at least every 5 years, but with more frequency with those that have abnormal bone density scans. Our center needed to improve our matrices in our adherence to guidelines, improve follow-up with abnormal bone density results, which would have a positive impact on patient outcomes through earlier identification and intervention. We developed key drivers that identified interventions and processes with visual pathways for the aim of this project. By using the FMEA, we realized the deficiency in identification of patients with abnormal bone density results, lack of knowledge and education leading to bone densities not being ordered, non-adherence to scheduled appointments and interventions. So the results of our study showed that we surpassed our initial goal of education, patient education, and bone densities being completed. There was increased compliance with the patients receiving DEXA scans at the recommended interval. We noticed decreased no-show rates to bone density appointments, especially if the appointment was scheduled on the same day as their quarterly CF appointment. What I learned through this process is that communication is an integral part of any QI project. In this project, communication between all team members, answering the who, what, how, when, and why, and then answering why, where, and how to the patients was an evolving process. Continuous evaluation of what is working and flexibility are key to any QI project. The tools used can be utilized in other areas to improve adherence to CFF guidelines. Our team was able to see the positive impact it had on our patients, and our patients benefited from increased knowledge, which empowered them to make informed decisions, while helping them understand why the bone densities are ordered. I'm interested to see if this education will have an impact on the patient's vitamin D levels, which was part of our education, and if continued education can benefit other areas of patient care.
Great job, Barb. And next we'll hear from Cassandra Grimes.
My name is Cassandra Grimes, and I'm a family nurse practitioner with Helen DeVos Children's Hospital with Corewell Health in Grand Rapids, Michigan. The title of my project is Improve Monitoring for Liver Disease in Pediatric Cystic Fibrosis, a quality improvement project on abdominal ultrasound ordering. This was conducted at Michigan State University CF Center. CFF guidelines recommends obtaining abdominal ultrasounds at least every 2 years in pediatric patients starting at age 3 until late adolescence. Our center needed to improve our rate of ordering these ultrasounds for the overall enhancement of patient care. We developed key drivers that helped prioritize change ideas and provided a visual pathway for the aim of this project. Through the utilization of the Simplified Failure Mode Effects Analysis, SFMEA, we found delays in the time of abdominal ultrasounds being scheduled and completed. Results showed our team succeeded our goal in ordering abdominal ultrasounds. However, despite the best laid plans, all the ultrasound results were not received. So what lessons were learned? One must be flexible when collaborating with team members on a QI project and trying to schedule team meetings. There was a major event that occurred at our center that caused us to pivot during this project. This QI project was valuable for our patients and rewarding for myself and my team members. In terms of the next steps, we will continue to order abdominal ultrasounds per CFF guidelines. Thank you.
Wonderful. Thank you so much to our diagnostic testing group. We'd love to open it up for questions and discussion. So please come to the microphone or use the app.
Thank you for all the great work you guys are doing. Quick question about the DEXA scanning. Was insurance a barrier in many of the patients? Because insurance.
So to repeat the question is insurance a barrier?
Many times you do not have a diagnosis. CF is not a diagnosis that, basically you are allowed to order a DEXA scan.
So there was 2 patients that we did have a barrier because they didn't have Medicaid, they didn't have insurance. But when you're able to I think the diagnosis we'd use would be an abnormal bone density, which would allow them to get their bone density scan. So insurance, the only time insurance was a barrier was when they didn't have insurance of any
You have
sort.
to have a prior bone density to know that it's abnormal, basically.
Right, but when they're children, or the other part of it too is you could use abnormal BMI or nutritional deficiency, or chronic steroid use,
Yes, which some of them do. That's usually
which
the way
would
around.
account for it. Yes, sir.
One thing I keep hearing again and again with these 4 presentations is flexibility, flexibility, flexibility. I don't know if, I know Cassandra, you had to be really flexible. But does anybody have any quick tips about how to overcome some of these barriers and stay flexible? Yes.
I would say one of the biggest things is to make sure that you involve your entire team. So you've got the care team, but when you've got a QI team, you make try to have as broad a representation as you can, not only within your team but even outside. I mean, we had one project where we actually included the environmental services, basically the custodians, in the project. It was room turnover. We couldn't get patients admitted because they weren't turning over rooms, and so we actually brought them in, and they sort of felt really valued and respected. And it actually helped us, help them prioritize the rooms for the CF patients. So the broader the team, you make people feel valued and respected by bringing them into the team, and it often helps move things forward.
Thank you. Oh, I'm sorry. Go ahead, Jen.
I did have a question. You guys wonderfully illustrated which tools you used in your process. I know you had excellent support to learn about these tools. How did you then share your knowledge and get your team on board? I'm assuming some of your teams weren't familiar with like SFMEAs and the like.
Thanks, Jenny. So at the University of New Mexico, I would share the resources that we would be using prior to our meetings to give everybody an option to familiarize themselves with a specific charter or tool. And then we would discuss it briefly at the beginning of the meeting. I was fortunate that my team was really engaged and they're wanting to learn QI, so that was helpful, and I was able to get several of them to actually sign up to do the IHI learning tool. So we'll be able to use that in the future.
Thank you. Thank you. Next, there's a question from the audience. What strategies do you use to improve the ordering process? Do any of you want to take that?
That would be our last question.
So I'm not the care coordinator, but I act as the care coordinator. And so literally, we have weekly huddles. And in preparation for our weekly huddles, I dig through the chart. And one of the things that I realized with our EHR is in Epic, they have what's called a Post-it note or a sticky note. And so on there, I have been now adding like BMD was done and is due so that I don't have to dig through the chart. And I order the bone densities or whatever labs that are appropriate for those abnormal screenings ahead of the appointment so that it's ordered. And then we also created smart sets so that everybody receives the same education. And even if the provider forgets in their after visit summary, they're getting that information. So hopefully that answers the question.
Thank you. Thank you.
Your microphone.
Okay, it's on now. Anybody else want to address that question? If you could come to the microphone.
This is a different question. But specifically for the sputum collections, what were some of the methods that you used to increase sputum collection?
So after we talked with the patients, a lot of their barriers had to do with doing it in front of people. A lot of them have a preconceived notion that they just can't cough up anything anymore. So giving them time, we ended up giving them their sputum cup at the beginning of the visit. So if nobody's in the room, we would have them trying all the times. On our wall is huff cough instructions. All the care team members along the way have a discussion about why is it important? How can we support them? Do they need more education? And those things really did turn out to be significant.
Thank you, Michaela. We have one more question, and this will be the last one from the audience. For the DEXA scan, are you having support staff make the DEXA appointment before the patient leaves, or are you scheduling the same day as the clinic appointment to reduce days that the patient has to take off work? Again, Barb.
So on our DEXA scans in our clinic, when we put the order, we do a scheduling comment asking them to please schedule that appointment with their follow-up CF appointment or other specialty clinic that they may have. We really try, we do a lot of diligence in trying to schedule their endo appointment, their CF appointment on the same day. And so we'll do the DEXA scan the same day, if and whenever it's feasible.
For the pediatric DEXA QI, unfortunately, my center does not have a whole body DEXA scan on the same day as our CF clinic. And we were unable to make that change as of yet. So we are giving the families the phone number currently to schedule. And since we did not see as high of a completion rate, we will be utilizing, like I said, our social worker to help schedule those appointments during their visits with us.
And I might invite Cassandra to comment as well, even though it's liver ultrasounds, kind of the same
So
process.
we would have our nurse put the order in our system for the ultrasounds to be ordered. However, because our center, Michigan State University, is located in the absolute center of the state of Michigan, our patients were traveling from many areas to come for their appointments. So it was very difficult for us to actually schedule appointments for them. If they traveled an hour to come see us, they might prefer to get their ultrasounds done closer to their home rather than what was closer to our center. So it was left up to the families to ultimately schedule their ultrasounds on their own, which resulted in, unfortunately, all the ultrasound results not being received because the appointments ultimately were not scheduled in a timely fashion.
Thank you. And thank you, diagnostic testing team.
Diagnostic testing.
Next, we'll be walking up lab testing. So the first presenter in this group is Samantha Kane.
Thanks, Sarah. As she said, my name is Samantha Kane. I am an adult nurse practitioner and program coordinator at the University of Pennsylvania's Adult CF program. And my project was focused on standardizing the process for ordering of our annual labs, which seems super simple, but so why was this important? As we know, the CFF care guidelines recommend annual lab screening for things like vitamin deficiency, hepatobiliary disease, CFRD, and in really focusing on our 2023 registry report, we found that we only had around 87% of our eligible patients getting their LFTs drawn annually, which was below the national average and just a little bit more concerning because we are really good at getting our eligible patients on modulator therapy. At that time, we had about 94% of eligible patients on modulator therapy. So this was really important. I had initially wanted to focus on how do we get more people to get their annual labs done, but with a center of over 400 patients, that was not happening in the 6-month time frame. So thankfully, after speaking with Dr. Donitz, he said, why don't you just focus on how these get done? That became more appealing when we looked at our high-level process map and found that we had no less than 6 ways by which annual labs were being ordered between pharmacy refills, dietitian visits, provider visits, and just phone calls with our RN and clinic coordinator. So the process, we looked at multiple PDSAs to finalize the process. We also looked at a prioritization matrix and just really found that small changes would be very effective. Our initial PDSA was just on what constitutes an annual lab set. I thought this would be done click, boom, and what happened? It turned into a whole internal discussion through emails about whether or not urine studies should be on annual labs because are they useful in non-diabetic patients? So came up with a final process of having this kind of 30-minute set aside on Tuesdays to review the next week's upcoming patients, pending an annual lab set for those visits when they were due in the next 3 to 6 months. I know that doesn't sound too novel because I know a lot of centers do kind of the pre-clinic meeting, but in our center, we actually look at all the patients from the past week. So this is kind of new for us. And we found that we were able to increase our annual lab sets ordered from 60% of eligible patients to 75%, which was not quite my goal of 80%, but we got a good bit done in a very short period of time, and it really had very little increased staff burden and no additional burden to our patients. So what's next? First, I do want to focus on getting up to that 80% goal and beyond. Next would be, how do I get these patients to complete these lab sets? And then this has kind of started a little bit of interest within our team to change our weekly meeting, and that's something we're actively working on right now. And what did I learn? Well, never assume anything. Like I said, I thought that first step would be super quick, done, over with, and it wasn't. 2, little changes really do have a big impact. I didn't do anything crazy. I decided to review charts for the upcoming patients, pen the labs, and it really did help get that done. And then just getting input from invested parties being crucial. I would have never guessed that there were 6 ways annual labs were being ordered, but in working with our pharmacists, our dietitians, our nurses, and our clinic coordinator, it was a little crazy. But yeah, so here's to the next steps. Thank you.
Thanks so much, Samantha. And next we'll hear from Carla Brutus.
Good morning, everyone. My name is Carla Brutus. I'm a family nurse practitioner with the Adult Center at Joe DiMaggio Peace Pulmonology Group in Hollywood, Florida. Undiagnosed, undertreated cystic fibrosis-related diabetes may result in decreased body weight, CF exacerbations, and worsening lung function. As life expectancy of individuals with cystic fibrosis increases, the risk of CFRD increases, affecting 40% of the adult population. Screening for cystic fibrosis-related diabetes, CFRD, according to the Cystic Fibrosis Foundation, should begin by age 10 and completed annually through the use of the 2-hour fasting oral glucose tolerance test. Our aim, a subset of our adult cystic fibrosis population, did not complete the oral glucose tolerance test in 2024. Our QI project aim was to increase the percentage of OGTT ordered within this population from 0 to 84% by July 31st, 2025. Communication and education occurred within our multidisciplinary team to ensure the tests were ordered for required patients. Several tools were used for process improvement. The high-level process map was used to identify our previous process for ordering the test and revised throughout our project. This map, along with a key driver diagram, was used to update our ordering process. Our project included 4 planned do study act cycles, also known as PDSA. During these 4 cycles, the oral glucose tolerance test orders were placed when patients were scheduled for clinic visits. Our outpatient team communicated with our inpatient team during hospital admission to help identify patients who were in need of testing. Our team also seized the opportunity for patient education and ordering tests when patients reach out to our office independent of clinic visits. Barriers were identified of ordering the glucose tolerance test and test completion, which included but was not limited to lack of patient education. And this was identified through the Simplified Failure Mode Effect Analysis tool, also known as the SFMEA, and High Prioritization Matrix chart. Through the use of the PDSA cycles, lessons learned included, but were not limited to, patients should not be presumed to fully understand the necessity of the test, even when managing a chronic condition. Providing patient education, issuing pending test reminders, and maintaining ongoing communication within the multidisciplinary team helped facilitate a positive outcome of our process, and they were crucial for success. Next steps for our center is to utilize QI tools to not only focus on the subset of the population studied, but rather our entire adult CF population who require testing. Thank you.
Wonderful work, Carla. And up next is Max Vetter.
Hi, everybody. My name is Max Vetter. I'm a physician assistant at the Primary Children's Pediatric Cystic Fibrosis Center in Salt Lake City, Utah. I'm excited to talk to you about my project, the development of a standardized lipid screening process at a large pediatric CF care center. So this project was really born from conversations our team was having about wanting to screen patients with lipid panels, but not knowing exactly who we should be screening and then what to do with those results, if we should be starting them on statins, if indicated, who we should refer to. So really had to start with a little bit of research to figure this out. And we found an American Academy of Pediatrics guideline stating that all children ages 9 to 11 years old should have a screening fasting lipid panel typically performed by their PCPs. We also found a lot of research showing that this is not happening in the general population. We then met with the head of the hyperlipidemia clinic at our institution to see if there are patients in addition to this guideline that we should be screening. And he recommended that we really just stick with this guideline and that there aren't necessarily patients that we need to be screening based on comorbidities. Then we wanted to figure out how should we do this. And trying to be cognizant of the fact that patients with CF already have a fair number of blood draws, pokes, trying to minimize the potential for medical trauma in children. And we know that our patients, starting at age 10, have to have an oral glucose tolerance test, which they come fasting to clinic for. Our institution additionally pairs our annual labs and OGTT every year to try to minimize blood draws. So it felt like a natural avenue to get their fasting lipid panel as part of this lab order set since they're already coming fasting. We did have a discussion with our cardiology colleague, with the question of usually the full blood draw happens 2 hours after they've had their glucola. Is that going to affect their fasting lipid panel because it's no longer completely fasting? He said that's more or less good enough, maybe a very small effect on triglycerides, but he said that that's fairly equivalent to a fasting lipid panel and we didn't need to worry. So we felt good about this process. And we were really happy to see we exceeded our goal and had a 95% completion rate during our testing period from May 1st of this year to August 1st of this year. The only patient who didn't have their lipid panel completed as indicated was because they were pretty sick at their visit and all of their labs were deferred to a later date. The biggest lessons learned from this project for our team were that having a clear written process leads to success. We had a lot of people helping with this who were not necessarily part of this QI subcommittee, from our fantastic nurses who were actually screening our patients and pre-clinicking to see who needed their labs done and trying to utilize the inclusion criteria we had given them to identify patients who would have their lipid panel with their OGTT, our medical assistants are calling the families to provide them reminders to come fasting. And then, from our phlebotomists to our providers actually interpreting the results, writing this all out for everyone. So it was very clear of what we were doing, who we were doing it for, and when we were doing, I think was one of the biggest reasons we were as successful as we were. Thank you very much.
Thank you, Max. And to round us out is Christy Woods.
Hello, my name is Christy Woods. I'm an acute care nurse practitioner with the Adult Cystic Fibrosis program with Central Texas in Austin. My project was on advanced cystic fibrosis lung disease. Advanced cystic fibrosis disease, or lung disease, I should say, or ACFLD, results in reduced quality of life and remains the most frequent cause of death in individuals with cystic fibrosis. The 2020 ACFLD guidelines provide recommendations on the management of care issues when individuals reach advanced lung disease secondary to CF. Optimized care management by the CF team is necessary to improve the rate of survival, especially in those ACFLD individuals that opt for lung transplant as part of their treatment plan. To improve our center's lung transplant referral process, we started small with a focus on ACFLD monitoring. We aim to increase the percent of ACFLD diagnostic orders from 0% to 70% in our ACFLD patients by July 31st, 2025. Our QI team consisted of 2 of our nurses, 2 of our RTs, our program director, and myself. We reviewed our process, or more pointedly, the gaps in our process, and gained a lot of knowledge from what didn't work and what was incorrect. A vital component of our QI process was a focus on the QI tools that positively highlighted the negatives, allowing our team to make successful changes. One example is the Pareto chart. It demonstrated the lack of diagnostic orders being submitted, but also pointed out the high no-show rate in our ACFLD appointments. Sorry, lost my spot. Our team is reviewing our clinical care model to determine a need for ACFLD specified appointment frequency. Also, we are looking at ways to improve our missed appointment management process. Another QI tool that you've heard this morning is the SFMEA, and this delineated the specifics behind missed diagnostic orders with details like partial order sets and orders submitted incorrectly, like the wrong test codes or submitted to the wrong facility. We created an order set within the EMR that included the correct test codes for the 6-minute walk test, VBG, and an echocardiogram with the correct facilities embedded within the order. We reached our goal of 70% after our July 31st deadline. The project has been extended and was at 79% as of September 30th. Further review is needed to address barriers like treatment burden with added diagnostics, the out-of-pocket costs, the effects of highly effective modulator therapy on ACFLD status, and non-CF related disease factors that affect lung function. I would like to thank the clinical staff with the Adult Cystic Fibrosis Center of Central Texas at Ascension in Austin, the members of the LEAPP leadership, and my LEAPP fellows for the support of this QI project. I would also like to extend my heartfelt thanks to our patient family partner, his wife, and his sisters. He was a great inspiration for continuing this work. Thank you.
Wonderful, Christy. I know this is especially meaningful. All right, we'll open it up for questions and discussions.
We have a number of questions from the audience. Magdalena Joseph has a question for Samantha King. She wants to know, do you have a staff member in your clinic who could conduct phlebotomy in your clinic space, or would your institution be open to training or hiring someone with the skill? Maybe patients could have their labs drawn in clinic.
Unfortunately, we do not. We had actually approached this subject at an earlier date to see if we could get OGTTs drawn in our clinic, and that got shot down. We do have a lab on the exact same floor as our clinic. The issue is that we have a pretty fair number of patients at our center who cannot have their labs drawn at Penn due to PA Medicaid rules and whatnot. So our Medicare patients are fully covered. A lot of our private insurance patients can get them there. And when we do have that happen, we do schedule same-day appointments as often as we can. But unfortunately, we have been turned down about the phlebotomist.
Go ahead.
I had a question for Christy about the ALD. You mentioned out-of-pocket costs. Did you find that there were particular tests that you look to pursue for these patients? Like, was it insurance dependent, or was there a common theme with like a particular test you had a hard time getting coverage for?
It was, in particular, the things that in the beginning we were struggling with, specifically the echocardiogram.
Yeah.
Because it was a process just to identify where we could send them on an outpatient basis where they weren't being referred to cardiology to then also have the results read. So we were able to work that out within the hospital, Ascension Medical Center, where they could go over, have it done outpatient, and then it would automatically be routed to a cardiologist to be read. So with that in mind, then it was how many of our patients have insurance, because like other centers, you have patients that come from hours away, and it's a question of would it be covered by insurance? And it's not a large percent, but you try to take care of all of them if you can.
No, it makes sense. When she started talking about that, I was like, yeah, I can see that being a barrier. So thank you for sharing.
Thank you.
Okay, for Carla, do you consider in the future using a CGM instead of OGT for testing?
Our team has not discussed that, but that is something that we will take into consideration.
Okay, and Max. So what do you do with your abnormal lipids? Are you treating or sending? What are you doing with those results?
That's a great question. So that was the next part of our process that we're kind of wrapping up right now, was to develop an algorithm with cardiology for what patients should just have repeat panels, who should be referred to cardiology. The cardiologist we're working with has been great and given us a pretty good delineation of at these elevations at this range, have them work on lifestyle modifications, repeat in 6 months. If it's at this level, just refer to me immediately. So we figured that out. That just wasn't done by the time I had to have this ready.
And then before you go away, could you talk a little bit more about your order process with the OGTT and fasting? Are you drawing it at the beginning or at the end?
Great question.
Say that again.
Yeah, so when we do our OGTTs, we're able to do them in clinic, which is fantastic. Phlebotomy comes up and they do a finger poke for the fasting blood glucose. And then once we confirm that that's within normal limits, we administer the glucola. And then for the 2-hour draw, we do a venous draw where we obtain the 2-hour OGTT value and all of their annual labs. And so we get the lipid panel at that time. That was part of the concern with our process, is we didn't want to add a second venous draw at the very beginning. And so that's why we discussed it with cardiology to say how much is, the glucola going to mess up their lipid levels.
Go ahead.
Hi, Max. Can I ask just actually 2 questions, if
Go ahead.
possible? On the lipids aspect, could you just comment what proportion had actually abnormal tests? Because you mentioned about the workflow beyond, but how much abnormalities did you actually find?
Yeah, I think we've had maybe about 35 patients undergo lipid screening at this point. We've had, I would say, maybe 5 to 10 with very, very mild elevations, 2 or 3 points over the upper limit of normal. We've had maybe 3 total so far who are engaging in lifestyle modifications.
Okay. Yeah. And then my second question, if possible, is around the oral glucose tolerance test. So at the previous center I worked at, we tried to put in place the same sort of thing. And one of the things we found was challenges with getting them to come fasting, because often they forgot or that was logistically hard. And it led to us actually adopting a modified approach based on pregnancy-based screening, where they come in and just have a glucose load and just see what it does. And that was easier to kind of implement within the clinic. And so I just wonder about what your experience has been in terms of getting them to adhere to coming in fasting.
Yeah, that's a great question. I was very fortunate that I piggybacked this off of another quality improvement project that one of my coworkers had done a year or 2 before to improve our OGTT completion rates. So they actually worked really hard to implement the process where we have our medical assistants call families the day before to remind them to bring their child fasting, to work on identifying ahead of time, oh, we need a morning visit for this patient. We serve a large geographic area, so we have a lot of families who want to come in for afternoon visits. So there was a key component of providing education to them of, hey, we need at least one morning visit a year. Here's why. We will try to help where we can with housing or hotels if eligible. So I was very fortunate that someone else has already done all the hard work to improve those completion rates. And because they were so high, that was another reason we decided to try to add this on.
Okay. And as a shared experience, we found the pregnancy-based approach a very effective way of screening who needed an oral glucose tolerance test, if you find it's logistically
idea.
Very cool. Thank you.
That is a great idea. Thank you. We have time for one last question. Regarding the annual labs, we're wondering if the inpatient, if they can be done inpatient and would they be considered annuals and completed?
So yes, we do try to do that when patients are admitted and due. The problem, I don't know if you'd call it a problem, is that we just don't have that many admissions anymore. So with a center of over 400 patients, that might capture between 5 and 10 per year, and we do work really hard to do that. But it's just such a small percentage of our population that it hasn't made such a big difference.
Thank you very much to our lab testing group. Great presentations, great discussion. Next up is Group 3, Potpourri, Your Center and Beyond. If you would approach the stage, thank you.
To kick us off with CF Potpourri is Danielle Canton.
Good morning. I'm Danielle Canton. I'm a nurse practitioner at Dartmouth Health Children's back in New Hampshire. And the title of this project is Partnering with School Nurses to Increase Confidence and Quality of Care. So the project was born when the New Hampshire School Nurses Association, when the New Hampshire School Nurses Association expressed the need for some education surrounding CF. I think the school nurses had expressed that the landscape was changing, but they felt lost in that, and they weren't quite sure how to take care of their patients or their kids at school. And simultaneously in our clinic, throughout the school year, we were finding kids coming in concerned because the nurse didn't know what to do about sick day care, or there were issues around lunch and what we were eating or what we weren't eating. And so we realized the gap, and it seemed like the right time to come up with a process. We had no process, and we didn't really have any formal education to give to school nurses in the area. So that's where this improvement project was born. And we realized pretty quickly when we did a high-level process map that we needed 2 steps. First, we need to formulate some form of education, and then we had to deliver it. So we created an education booklet for school nurses. It was based on a pilot WebEx that was given to them. So I did a WebEx, and we had obtained metrics prior to with knowledge and confidence level in caring for kids with CF. And then metrics after, how they felt. And we also obtained their feedback at that time on if there was any additional information that was not in this WebEx and this PowerPoint that they felt like they needed. So all of that was taken in combination to create the education booklet that we have. We felt pretty confident then that it was what they needed and what they were looking for. But step 2 was the process that we needed in clinic now to get this out there. So we created a system where we would give it to the patients and families to bring to their 504 meetings with their school. And at the same time, we realized that we also needed a way to communicate with school nurses, because that was part of the problem, is we didn't have the open communication. So we obtained a release of information at that same time. And if we could get the nurses' email or contact information right then we could just send an electronic version if needed. the results were really that the patients were so enthusiastic about it. You know, we did PDSA cycles, and I think there were a few tweaks along the way, but overall it was received so well by our patients, I think because they really felt the need for this, that we obtained our metric really early, actually. So our team obtained our goal of greater than 70% of the release of information signed, education packets given by the mid-August, when that was the goal for the end of September for the school year. The greatest highlights for me through this were really that it was a smaller project in the beginning that I was concerned about, like, is this enough? But it meant so much to so many people. Our Patient Family Advisory Council was involved and gave tremendous insight. School nurses, the community that we've created with them now with the New Hampshire School Nurses Association has been incredible. And the patients really were so happy about it. So it was a small project that I feel like made such a big change for us and for the community. And so moving forward, we'll be moving this forward with primary care providers who have seen this and now want an education piece for themselves. And also with the New Hampshire School Nurses Association, who's advocating now for some changes in legislation for our kids.
Good job.
Terrific work, Danielle. Next is Annie Sue.
Hi, I'm Annie. I am the nurse practitioner and the program coordinator at University of California, San Francisco, the Adult CF Care Center. So this QI project looked at improving the efficiency of our CF clinics, and it was identified by my care team as a timely issue for many reasons. Chief among those included, one, recent retirements, a lot of staff turnover, which meant a lot of new people that were either unfamiliar with the CF care model or unfamiliar with our team culture. And then two, working in this post-pandemic sort of highly effective modulator era, we have a lot of patients that have less visits annually and because they feel well. And that has led to prolonged clinic visits, clinics not ending on time, a lot of missed opportunities for patient care, if things are running over time and patients and care team members have to get to other appointments or clinics. And overall, just decreased care team satisfaction. I think I found the systems failure mode analysis tool. It was really helpful for us in mapping out like the current conditions for clinic workflows to identify failure modes and pain points, but also to identify the processes that were working really well for us and that we wanted to maintain. And then that set the framework for prioritizing them into a matrix to identify those interventions we wanted to tackle first based on effort and impact. The interventions that our care team had agreed upon included more closely staggering appointment times in the scheduling templates, ending clinics earlier, time stamping how long each care team member was taking with each patient, and then co-locating our care team in the same workroom. And each one of these interventions had their own PDSA cycle. We were generally pleased with the results, which led to a decrease in the median of clinic overtime from 31 minutes to 0. It improved communication amongst our care team members in real time, and it increased satisfaction amongst our care team members, our clinic staff, and our clinic managers. All without adversely affecting patient access volume and experience. One of the biggest lessons that I took away from this was to echo what Dr. Dunitz commented on earlier, involving as many stakeholders as possible from the beginning of a project really lends itself well to increased engagement, investment, and ultimately, hopefully, sustainability in the changes that you want to make. Thank you.
Thank you so much, Annie. Continuing on with our potpourri is Heather Moore talking to us about newborn screen.
Thank you. So I'm Heather Moore. I'm a pediatric nurse practitioner at the Children's Hospital of Colorado in Aurora. And as you all know, that early diagnosis and early treatment in cystic fibrosis lead to better outcomes, improved growth, improved lung function, and access to life-altering and life-extending therapies like CFTR modulators. So a little bit of history for you all. Colorado was one of the first states to implement CF in newborn screen in 1982. But despite this history, we found that we had only about 53% of our newborn screens in the state of Colorado getting in for their sweat test within 14 days. So how could we shorten this time from positive screen to getting a sweat test? So my project focuses on those infants born in Colorado and Wyoming with positive newborn screens, and we aimed to reduce delays and disparities in getting the diagnosis and treatment of cystic fibrosis. Our SMART aim is to ensure that 90% of positive newborn screens get in for their sweat test within 14 days. We had a secondary aim to improve overall completion of sweat tests as well. And so we hypothesized that by not having a consistent point person or follow-up system was leading to delays in getting our babies in for sweat tests. So we started mapping the process at a high level to understand what was actually in our control and where we could make improvements to improve the delays and mitigate barriers. So in Colorado, the primary care provider is tasked with alerting the family of a positive newborn screen and then providing them with the recommendations of where to call, how to get that sweat test done. And then the next step is up to the family, and they're just to call our sweat lab at their convenience to get their sweat test scheduled. So for this project, we identified a point person from our CF center to follow up with the pediatrician and assure that the family received the results and the recommendations. And then we called the PCP offices to find out within the first week that the results had been relayed to the family if the test had not already been scheduled. We ended up shortening that to 2 to 3 days because we found that waiting that 1 week was still just too long and created delays in getting that sweat test done. Once we verified that the family was aware of the recommendations, we had our sweat lab then actually call the family just to take the burden off of them. And then to streamline communication within our group, we created an Epic group chat with key members of our team. So it included the sweat lab, schedulers, and our family health navigator, then to reach out to those families to get it scheduled once they were alerted. Again, we found that waiting more of those than that 2 to 3 business days was causing delays. After reviewing the big picture and realizing what was actually in our control within our center, we learned that making small changes can really make a big impact in getting these babies in for a sweat test in a more timely manner. And then finally, through this project, I learned that by collaborating with and building relationships across departments and within our institution, we were able to streamline communication that further mitigated these barriers. And it's going to help us move into this next era of expanded sequencing at our center. And so thank you for listening, and come by my poster.
Great work, Heather. So far, we've heard from all of our fellows, and we're really excited that we have additional colleagues in the CF field joining to present their abstracts. So next, we'll be hearing from Liz Chaville.
Hello, I'm Liz. I'm a nurse practitioner in Queensland, Australia at the Queensland Children's Hospital, where we have a large paediatric clinic of around 460 patients. This is the story of my poster. So I'm privileged to work at a wonderful facility, and alongside of our CF clinic, there is an independent immunisation service. Let's see if this cursor works. But we have a historic problem. We have low immunisation rates in children with CF, in particular the influenza vaccine, or influenza rates. In 2022, after a lot of lobbying from our CF director and the CF charity, we finally got our first dedicated CF pharmacist. It's been a great addition to our MDT, and she was immediately concerned about our low medically at-risk immunisation rates. And she talked a lot about this, and we listened, and there wasn't a lot of action. In 2024, we received the results from the 2023 National Registry data results, and we were pretty happy with them. They were presented to the hospital executive, and they smiled, but they came back at us and said, "Why has your clinic got the lowest immunisation rates compared to the other clinics in Australia?" So straight away, the CF pharmacist was relieved. She joined with the immunisation service and they implemented a fairly quick and rapid intervention over a 6-week period, looking at immunisation history and targeting children that were coming to the clinic in that 6-week period. And they presented very positive results at our CF planning day. At the end of that, the pharmacist was very quick to tell us it wasn't sustainable and it was using too many of the pharmacy hours. So the CF leads got together with the immunisation service and we worked out a more sustainable plan. And it was said the CF nurses had to come a bit more on board at that stage. So the CF nurses and other members of the MDT we were supported to attend an immunisation workshop. We did a lot of education with the immunisation service about infection control in our clinics. And we warned the parents by newsletter, phone calls and email that when they next visited our wonderful facility, their child may well get a vaccination from the immunisation service. 6 months later, the NP, me, did a quick audit, well, not that quick, but just over 100 patients and looked at whether advice had been taken up and how things were looking. And that was done by looking at the electronic record and also the Australian Immunisation Register. Now, while there was some promising results there was evident there was still a lot of work to be done. The immunisation service had stood back a little bit during that time. They had done a gap analysis on every child in the clinic, so we knew where the gaps were, but it became a little bit more dependent on who was working in the immunisation service that day. And from our clinic, we'd ring them and you'd kind of know whether we'd get action or not by who answered the phone. Overall, what the learnings from it and what's come out is that the CF nurses need to take more ownership. We need to use the MP role better of ordering. We have just secured a new vaccination fridge in the clinic. We're getting the pneumococcal and influenza vaccines up on Impress. And we need to work a little bit closer with other departments in the hospital as well. But overall, we just got to remember our outreach patients who don't have easy access, and we will continue to work at improving our immunisation rates.
Thank you so much, Liz. And next we'll be hearing from Irina Gutman, presenting on behalf of Christine Decker-Hughes.
I'm going to continue this pharmacy nursing collaboration in immunizations and importance of having a collaborative approach. So, good morning, everyone. Adults living with chronic disease, especially those with CF, face a high risk of severe respiratory infections. Yet the vaccination rates among these vulnerable individuals remain pretty low. At the University of California, San Diego Adult CF Clinic, our RSV vaccination rate was just 7.7%. With approval of the new RSV vaccines, Abrysvo for adults 18 to 49 for patients with chronic lung disease and Arexvy for those 50 plus with chronic lung disease, we saw an opportunity to make an impact. Our goal was clear: to increase the RSV vaccinations from 7.7 to 10% by April 30th, 2025. And there is a typo there, it should be 7.7, not 7. This project was conducted as a part of Christine's Lean Six Sigma Green Belt certification. We used the A3 problem-solving model, a structured, data-driven approach to quality improvement. Using the Lean tools, we identified the barriers that prevented people with CF from receiving the RSV vaccine. 3 key issues emerged: limited vaccine access, lack of standard patient education, and inefficient ordering and documentation process. From there, we have developed and scored potential interventions, focusing on solutions that would have the highest impact with the least complexity. We implemented 3 major changes. The nurse created a patient-friendly vaccine education handout, and our providers discussed the importance of vaccinations with patients in the clinic. Our pharmacists obtained in-clinic stock for RSV vaccine and ensured the order was set in electronic medical records. our team streamlined the workflow process. The interventions were launched on March 18, 2025, and the data collection concluded on April 30th, 2025. Within just 6 weeks, the RSV vaccination rate increased from 7.7 to 10.3%. While the numerical change may appear small, this represents a meaningful progress for a specialized patient population and reflects measurable improvement in workflow efficiency, vaccine accessibility, and patient satisfaction. This project demonstrated how lean methodology combined with frontline collaboration can remove barriers and enhance patient outcomes. Looking ahead, our steps include expanding the RSV vaccine access to our other CF clinic locations, educating community pharmacists and primary care providers about vaccination recommendations for people with CF, applying the same lean strategies to improve rates for all respiratory-related vaccines. Ultimately, this Green Belt project was about more than just approving a number. It was about simple measures to protect the health and quality of life for adults living with CF. When patients are informed, when vaccines are available, and when systems are efficient, this type of preventative care becomes possible. We would like to thank and express our greatest gratitude to all members of our multidisciplinary team at UC San Diego Health. Through lean thinking, we proved that every small change, focus can lead to meaningful, measurable impact, one patient, one vaccine, and one improvement at a time.
Thank you so much to our LEAPP fellows and our CF colleagues for presenting. We'll open it up for questions and discussion.
I'll start with a couple questions from the audience. Patricia Banks asks, for Heather, was the QNS rate at your sweat lab, or what is the QNS rate at your sweat lab? And another follow-up question from Trevor Spoford for you is, for sweat chloride testing, did you find that the need for physicians to discuss the positive newborn screen in person made it difficult to see patients within the target of 14 days, meaning scheduling challenges?
I'll start with that one. I feel like we've learned through this process that our families get a variety of recommendations depending on their pediatrician's office. Sometimes it's the MA who's just calling saying that there's a positive screen. And so a lot of families don't have a lot of background or information. So I think that's next steps in this project of like what we can do next to help improve patient family understanding, but also PCP understanding, and having or allowing the PCP offices to provide more information to the families. And then our QNS rates, I don't know exact numbers. I don't feel like they're very high. I haven't gotten a lot in this project in general.
I have a question for you. So Colorado, do you do IRT, then DNA?
Yes.
So having to get that second IRT could be another reason to prolong the time.
Yeah, so that's exactly why we had to look at what we could do within our institution and not at the state level, because that's just beyond what we could do.
Paul Robinson, Brisbane. A question for Christine. So can I ask, how did you come up with your target of 10%? And now that you've achieved that, have you now revised your target, for future work to try and get higher?
Yes, the goal is to essentially vaccinate or provide education and vaccination for all of our patients. That's the next steps. We currently have 2 clinic locations, and one has easy access to vaccines in terms of it is a part of it's a part of health system where we have a Pyxis machine where the vaccines are loaded. Our other clinic is located in non-clinic licensed space, so access to vaccines is a little bit more challenging. So the goal is to improve access in our other locations. In our other location that will help us to boost the vaccination rate. So ideally, we would like to make sure all of our patients are vaccinated. So that's the final goal. In terms of how we decided to increase 7.7 to 10.3, we just wanted to see, we only knew Christine did it as a part of her Lean Six Sigma project, and she had 6 weeks to complete. So she wanted to create a meaningful measurement, wanted to see that she's going to be able to achieve 10% rate and just have a roughly 2.5% increase.
I mean, just as a comment, it's very easy to aim for something more aspirational, but I think what she did or what you did collectively was aim for something you could achieve, which then creates momentum. So I thought it was quite clever.
Thank you.
Just a quick comment for Danielle. I don't think I was the only one who was really excited to hear about your booklet for schools. I am a new member of the education committee, and one of the things that I brought up is the need for a booklet for schools, as the one we had been using is no longer in publication. So just a kind request for you to submit that to the CF Education Committee so that everyone could have access. Thank you so much.
Thank you. More opportunities for Danielle. Next, there's a couple questions I think our vaccine people may need to hover. Angela Oder asked, I've had several patients who are interested in RSV vaccine, but they were denied because they were under 60. This is a U.S. problem, by the way, Elizabeth. Have you encountered this problem and how did you resolve it? And another question that is kind of piggybacks on that is, which patients received the RSV vaccine? So how did you select your candidates by lung function, age, and did insurance cover the vaccine? And that is from Jill Fleege. Thank you.
Both are great questions. So the first one, accessibility. When you administer vaccines in clinic, we identify patients and administer, so there is not that much of an insurance issue. At the beginning, when we didn't have access, so we started with targeting the initial approval for RSV was 65 plus, or whatever the initial age approval was. We didn't have access in clinic. So we send the orders to local pharmacies, and that's where we faced the problems that you are describing. We couldn't get them approved. So we identified the barriers. We spoke with the pharmacists. We called the insurance to get an authorization for the vaccines. We also later identified that some of the pharmacies had their guidelines and protocols updated while others haven't. For example, CVS Pharmacy was easy to order and get the vaccines approved. We would provide package insert and recommendations to the insurance. When the vaccine became more broadly available for patients 18 plus with chronic lung conditions, it also became a challenge. The same process needed to be done. We either needed to obtain the approval with the insurance first if the rejection was happening at the pharmacy level, but later some of the pharmacies started to update their guidelines. It was much easier to get the vaccinations done. But it is also a part of our next steps of education of the local pharmacists and local pharmacies, as well as healthcare providers in the primary care arena. In terms of the access within the university, we also had to go through Pharmacy and Therapeutic Committee, bring the new updated guidelines and say, well, it wasn't guidelines, it was package insert that allowed patients 18 plus to get RSV vaccine. Now, how did we identify patients who needed everyone? At the beginning, it was 50 plus or 65 plus, then 50 plus. But then later on, when the package label recommended 18 plus, we recommended it to all of our patients who were 18 plus. And that is before the new recommendations and guidelines were posted by CDC, who now recommend, like the agency currently recommends 50 plus. So now we're in this kind of window of the package insert allows 18 plus. The recommendations from CDC talk about 50 plus. We identify high risk patients, the patients who have advanced lung disease or frequent exacerbations, or whoever the team, the multidisciplinary team identifies to be at a high risk for RSV infection.
Thank you. I was wondering if, Elizabeth, you had any thoughts to follow up on your experience. I know you don't have to deal with all of the same eligibility and different payers that we do, but did you encounter any challenges?
No, the greatest enabler for getting vaccinations done is to have them available in the clinic and ready and waiting. And in Queensland, influenza and the medically at-risk vaccination, which is what I looked at, are all free of charge in 2025.
We want to be like you. And then one more question.
Yes. I have a question for Annie. I'd love to hear you speak to your project being a multidisciplinary team, and how did you incorporate team member voices in choosing your interventions?
So actually, it was an interesting project because I actually went to my care team and I asked them, you know, what would be a really meaningful project for you guys. And so they were the ones who identified this topic. So there was a lot of buy-in from the beginning to have this done. And then I also wanted to include like clinic managers who had control over our templates and our schedules and rooms and things like that. And then I also wanted to include the clinic staff, like the medical assistants who like room our patients and are very much a part of the whole like clinic workflow process. So even if they couldn't attend all of our QI meetings, I did go up to them like separately and just like went through like the project and, you know, got their input. So.
Great job. Anything else for the Potpourri group? Thank you, Potpourri group.
Great. I hope you're all as amazed with their projects as we are. And our final group today is transition. So please come forward. So this last group of presenters includes two of our LEAPP fellows, Kristen and Gina, and then we have a former LEAPP fellow who was in the first cohort of LEAPP, Angela, who will be our final presenter. So Kristen, welcome to the stage.
I'm Kristen Crushell. I'm a pediatric nurse practitioner and program coordinator at Children's Wisconsin in Milwaukee. My project was enrollment in the CF RISE transition program. One of our patient and family partners shared with us that the thought about transitioning her 12-year-old son to adult health care keeps her up at night. And the weight of her words inspires me to continue partnering with her and other families to ease their burdens, which is something we all have the privilege of doing. To give you a little background about my project, we were using printed materials from the CF RISE website to discuss transition education at our center. But we were having difficulty tracking who completed what education and when. So we used the LEAPP program as a platform to enroll patients in CF RISE as the first step in standardizing transition education at our center. Our team wanted to explore what would be the most helpful interventions, so we decided to implement weekly PDSA cycles that were cumulative over time. At a certain point in time, eligible families were receiving this information at multiple different angles. And of course, we hit barriers. I found it insightful to sit one-on-one with our eligible families to learn what was really going on behind the scenes. Then we used QI tools to discover our most prominent barriers, and our biggest barrier was the lack of cell phone service and difficulty connecting to the Wi-Fi in our clinic space. We came to the conclusion that it was infeasible to have our families use their own personal devices to complete the enrollment in clinic. At that point, we abandoned all of our previous PDSA cycles and started using iPads in clinic. I'm happy to report that we have enrolled 74% of our eligible families in CF RISE at our program. As I reflect on my experience, I'm grateful for the partnership with our patient and family partners, for teaching us the significance of this topic and also helping us to identify unforeseen barriers along the way. Because of the LEAPP program, I now understand the significance of using QI tools to discover the real barriers and ways to overcome them. And finally, I learned the importance or when it's appropriate to foster a group discussion within our QI team, and when it's okay to make a decision independently. This is the first step in a large longitudinal project. Of course, transition is huge. We all know that. And being a LEAPP Fellow graduate puts me in a unique position to continue leading QI at our center. If I can help one mother sleep better at night, I will sleep better too.
Thank you so much, Kristen. And to continue on our transition journey is Gina Sire.
Hi, everyone. My name is Gina Sire, and I'm a pediatric nurse practitioner at the Pediatric CF Center at Washington University in St. Louis. And I want to invite you all to hop on in and journey through my QI project on the completion of a baseline readiness assessment tool with our adolescent patients at our center. So with any trip, you have to decide, where are we going to go? What's our goal? Our aim was to improve the transition process for our patients and families and identify individualized strengths and goals. This is important now more than ever, especially in the era of highly effective modulator therapy, as our patients are living longer and more fulfilling lives. So we picked where we're going to go. How are we going to get there? Our team decided on using a commercially available transition readiness assessment tool. And then our high-level process map really served as our roadmap to help us meaningfully and intentionally implement the completion of this transition tool during scheduled clinic visits. So the passengers on board with us were our pediatric patients diagnosed with CF ages 12 to 20 years old. And due to the paper format that we used, this was only administered during in-person clinic visits. So our bags are packed and we're ready to hit the road with a goal completion of 70%. To keep us in check, our key driver diagram really helped cluster our interventions that we were going to do for PDSA cycles. And the 4 themes that we had with that were clinic preparation, knowledgeable staff administering the tool, making sure that patients had enough time and uninterrupted time to complete the tool, and then safe and secure storage of the completed tools. And I am proud to share that we exceeded our goal and had a rate of 97% completion. On this trip, as I reflect on it, there were moments where we were in cruise control. And I credit that to the partnership that we had with our patients and families who were so willing to participate, as well as the team that was dedicated to this project. We had all hands on deck. One of my favorite parts of using this transition tool was an added bonus of patients adding handwritten goals, which I really felt like put a glimpse and perspective of what really was important to them and how we can help tailor based on their goals and their needs. And so while there's moments where it's smooth, you also hit bumps along the road and detours. And that really was our biggest challenges were with tracking. So when we had patients that were scheduled for appointments but had to reschedule last minute or missed or no show. And then of course the challenges of using a paper tool rather than electronic. Transition is a cross-country road trip, so this is just one stop along a very long road. So we have a lot of exciting progress to come on the horizon. So our next steps are going to be scoring and interpreting these completed tools, finding avenues to reach all of our patients ages 12 to 20 years old. Of course, developing some type of electronic format to help with distribution, and then shared knowledge and continuity of care by sharing these completed transition tools with our affiliate adult CF centers. So stay on board with us, and I'll be excited to share next year what our progress has been. Thank you.
Terrific job, Gina. And our final presenter today is Angela Oder.
Hi, everyone. I'm Angela Oder. I'm the nurse practitioner at the University of Cincinnati, and my project is improving patient experiences in the post-HEMT era. So as we all know that the landscape of CF is rapidly changing with the introductions of highly effective modulators, and as a result, more young adults are transitioning from peds to adult CF center. So this process brings new challenges like learning to be independent and navigating adult goals. So the aim of my project was to understand the experiences of patients transitioning from peds to adult CF care and identify their barriers, facilitators, and opportunities for quality improvement. So what we did is we conducted virtual interviews with 8 participants under the age of 21 with a live artist who drew out their words and made a map that they compiled. So 7 of these participants had already transitioned to the adult center and 1 was in the process. We used a hybrid qualitative coding approach to reveal inductive and deductive themes. And the QI tools that we use was process mapping to outline the transition pathway, and patient surveys were created to guide future interventions and evaluate these processes. We also use thematic analysis, which allowed themes to become actionable strategies. So the key findings were that participants were felt better and they were very hopeful on these highly effective modulators, and they were planning for the future. Most of them have plans for work or attending school. Some of the main barriers that they discussed was like parking difficulties at the adult center, incomplete handoffs of specialists, and medication access issues and insurance barriers. And some of the facilitators that a lot of them discussed was advanced preparation with information packets, seamless communication between the adult and the ped center, and uninterrupted access to medications. So some of the QI interventions that we did is we standardized a transition packet to be given to the ped center to give to future people who were transitioning over. And the packet consisted of photographs of ourselves with contact information of the adult team. It also had my chart instructions and parking map of our facility, and then key information such as the hours that were available and location. We also improved communication through quarterly newsletters with important updates and reminders, and we shared these updates via my charts. We improve ongoing collaboration with continuing to meet quarterly with the ped center and reviewing upcoming patients to identify potential barriers prior to transition. So the lessons that we learned is even with highly effective modulators, people with CF still need strong education, coordination, and emotional support. And frameworks like CF RISE provide a foundation, but still must evolve to meet today's challenges. So the next steps that we are planning is we're planning projects based on fertility and family planning to discuss fertility early in the transition process, emphasize the importance of gynecology care for women, especially those not on birth control. And we're going to continue with the transition process improvement with the ped center. And in closing, I just want to say supporting people with CF through transition means preparing them for adulthood, not just adult care. A patient-centered coordinated approach ensures a smoother, more successful transition. And I just want to thank the Boomer Esiason Foundation and the Cystic Fibrosis Foundation for supporting this work.
Wonderful, wonderful job. Our hospital is located on top of a hill and we have a tram to get there. So providing parking information would be huge for our patients. So it just goes to show that quality improvement, no matter how big or how small of a scale you choose, can provide really meaningful impact for the people we serve. So once again, question and discussion for our transition group.
So for Kristen from the audience, they want to know how you disinfect the iPad in between patients during the busy clinic, and do you have like an OtterBox on it or something? What do you do?
That's a great question. We found plastic disposable iPad covers, so they get taken off after every use and discarded.
That's yeah, recycled, I hope.
They're found on Amazon.
I was wondering if maybe Angela and Regina could address this idea of some of the sort of subjective data or information you received either in the comment section, or as Angela talked about, that early process where you picked up these themes. Maybe just talk a little more about that and the value it brings to your project in ways where you sort of think you know all the challenges and all the barriers, but it's really the patient voice that brings the project to life and helps focus it. So, any comments?
Yeah, so one of the things I would just like to piggyback on is like just the insurance piece. So when we were speaking to these participants, it just didn't seem like they had a lot of insurance knowledge. And so a couple of them even said, well, I've never received a bill in my life until I came to your hospital, and then I'm receiving bills in my name, and my mom always took care of it. So we talked about what that looked like, and even though you're on your mom's plan and your mom, but these will be your deductibles and what that means for you. And then also eventually there's going to be a time where you will need to get your own insurance as well. So a lot of conversations about that. And our social worker is amazing with having these conversations as well. And we would always clue in Compass to help with those.
So we had a wide array of comments back of what were some of the most important goals for patients. One that stands out that was a common theme was scheduling an appointment on their own. And so a lot of times the mom is calling or the dad is calling and scheduling them. And so helping in clinic our nurses, the next step will be the nurses to help sign them up for MyChart. After the age of 12, they have to have their own independent email address to be able to do so. But with that can help. The nurses also will schedule their appointments during their clinic visits so they can talk with them and pull up their calendar. So it kind of helps with viewing when your visits are, and then of course enhanced communication. But as we kind of go on that next step of scoring and interpreting our tools and looking and trending more of those handwritten results, I'm sure there'll be a wide extra projects, different areas of avenues to go down with that. So I'm excited to see where that takes.
Thank you. Abe?
Yeah, thanks everyone. These have all been great projects. Angela, question for you. I'm still trying to formulate the question as always, but can you talk a little bit about your experience in identifying and obtaining grant funding for your project?
Yes, excellent question. So we have a research coordinator that I work really closely with, and she kind of scopes out the grants as well. But as long as, and I do as well. So I kind of Google potential grants. And so we both came upon this Boomer Esiason grant. And it was a nice grant for somebody who was early career APP. And the process was fairly easy. No, I wouldn't say easy, but there was lots of revisions. And then I would write up the question and then the background information. And I would send it to my peers to review it and then re-edit it again and then submit it. And so once they approved it, which was very exciting, I received the letter, and then we would have to go through the channels of signing the contract and whatnot. But it was an excellent experience of attaining this. And there's also another grant funding for the, I think it's American Nurses Association, for group projects and individual projects. That's my next goal.
Fantastic.
We have another question from the audience. How do you keep the welcome packets from being too busy or too long? Sometimes I think we get overwhelmed patients with a bunch of information. Are they going to read it or throw it out?
That question is real.
Yes. So I think we have narrowed it down to 4 pieces of paper in the packet. One was a picture of all of our team. And then the second one is just information about our facility that has a little small section on where to park. And then our hours and MyChart information as well. And then there's a little small section on along with our pitches of who we are, what we do. So there's our pharmacist is in there that talks about medication access, which a lot of our participants said was a lot smoother on the adult side, which was really interesting, I found. And then the fourth
page that we put in there, which I'm thinking about taking out to make it less busy, is what to expect when you're admitted. So it just kind of talks about, because we've had not a lot, but I would say we had like 5 participants that were admitted from the ped side onto the adult side, and it was a huge different experience for them. So we just kind of put a little blurb in there about what to expect when you're admitted on the adult side.
Thank you.
I have a question for Kristen. I know your team worked really, really hard and ran multiple PDSA cycles. Could you speak to how you use data to inform which tests you continue to adapt and which ones to abandon?
Yes, so I didn't go into great detail about the tools that we used, but I think the most helpful was the SFMEA and the prioritization matrix. So we really spelled out what was our lowest effort, highest impact, and we kind of exhausted. After doing the prioritization matrix, we realized we've really exhausted all of our opportunities. So we need to go to a higher effort, higher impact, which made us decide to use the iPads in clinic.
And use Amazon.
Shameless.
It is shameful.
Oh, great. Go ahead.
This is kind of a general question, but for early CF career APPs who have not had the opportunity to do a lot of QI, what resources would you recommend starting with if you're interested in bringing a QI project to your facility?
Wonderful. I really appreciate the question. We will be launching LEAPP QI, which is a dedicated quality improvement course for advanced practice providers. That will begin this January. It will be published on the listserv. We also have a QR code available for those that are interested. So please come up to me after the session. We have Cindy George, who's pulling it up right now. We hope to offer this opportunity to 20 advanced practice providers, so that way we can really provide hands-on coaching along the way and support you with your project. No quality improvement experience is needed. If you have some, great. If you don't, come too. That's what it's for. Again, it's really hands-on learning. The CF Learning Network is also a great resource. They offer drop-in QI series that typically occur in the winter months. So again, if you're interested, please come find me. I'd be happy to connect you with that resource.
Thanks, Sarah. And with that, we will conclude this portion of our session, the workshop.
Thank you. Thank you to all our presenters, and thank you for attending.